Hello, everyone, and welcome to the Toronto General and Western Hospital Foundation virtual Q&A. I'm Christian Coates, host of the UHN podcast, Behind the Breakthrough. And we're glad you could join us once again, and we're grateful to you, our family of supporters who've been so generous throughout the COVID-19 pandemic. So a big thank you on behalf of the foundation and all of UHN. So this week, it's the Return to School edition. And as always, we'll be taking your questions. To help us understand the latest on the COVID-19 pandemic, we're pleased once again to have the expertise of Dr. Alon Vaisman. He's a UHN infection control physician. And welcome to the live stream, Dr. Vaisman.
Thank you for having me.
So we're nearing the end of summer, and of course, the question on everyone's mind, can we safely send kids back to school? I read recently a poll that revealed I think it was 40% of Ontario parents don't intend to send their kids back to school. From your perspective, are the discussions and strategizing about safety protocols being rushed?
There's a lot of work that's got into developing the strategies in Ontario and across Canada from experts in the field in infection control and infectious disease, such as at sick kids, and then also public health experts. So I wouldn't call the plan rushed. I think there's going to be still some unknowns that are going to be present when the schools reopen. There isn't ever going to be a scenario where it's going to be zero risk, and that's going to be, I think, a challenge for some parents because everyone has a different risk threshold when they consider sending their children back to school and the potential risk to themselves and their loved ones at home. So the plan is a starting point. It's a place that it's a safe starting point to start off with when schools are opened up in September, and things could very well change. And people just have to be ready to adapt, unfortunately, to a rapidly changing situation.
Okay, so much of the debate, as we know, is focused on class size and masking. What would be your guidance from an infection prevention control standpoint on these two issues?
I think a lot of what's been discussed in Ontario are correct in terms of trying to minimize class sizes. Aiming for as little as possible is the ideal. Nobody really knows what that value is, and that depends on the size of the class and the nature of the activity going on in the class. Aiming for somewhere around 15 students per class is a reasonable choice. The thing with that is that you have to be able to balance that with being able to educate the children with appropriate levels of staff and the appropriate size of the physical space too. So that is going to be a challenge for some schools. And in terms of masking, we should encourage as many students as possible to mask. There are some concerns around masking for some individuals who have challenge with English as a second language, being able to read and understand facial cues, for example, or children with disabilities, with learning disabilities, for example, or children with hearing impairment. So there are some things to consider when wearing masks that may negatively impact the child. But I think in general, most experts would agree that as much mask wearing as possible in most students is ideal, is what we should be trying to aim for.
What's your sense, Dr. Vaisman, in terms of something like a screening protocol for schools? Should there be screening or temperature testing or even saliva testing, say at the beginning of each school day as everyone arrives, and that's staff, teachers, students? Would that be useful from a prevention perspective?
Yeah, so if we take those items one by one, the saliva testing is, if it's very rapid, I suppose it could be a solution. It could be something that could be offered. Right now, we don't have a rapid, reliable, sensitive, and specific test that can be done on a daily basis. The thing about doing testing in a person who has no symptoms is that you've only ruled out the disease for that moment. So it's not ruling out the fact that they could be incubating the disease and present later in the day. So currently it's not an option, at least not a feasible option. As for temperature checks, many people with the disease don't have fever at all. So the test of doing a temperature check every day is not sufficiently sensitive. Also, people can have fluctuating fever with the disease, and also people can suppress a fever with Tylenol or other medications. So temperature checks are also not reliable. But the third item, which is syndromic surveillance, that is to ask everyone who enters a school, how are you doing? What are your symptoms? Have you been traveling? Have you been exposed to anyone with COVID? That is certainly by far the most effective way to screen out people with the disease. And that's what we do in the hospitals, and that's what people do in healthcare settings across Canada, is to do a symptom check every single day.
Right. Okay, what about aging infrastructure? Because some schools, that's an issue, right? And when it comes to ventilation, it's become a concern. So what's your sense of the risk in terms of aging infrastructure and the ventilation that's in place?
If you look at the Sick Kids document that was released, that was updated in August regarding ventilation, they very correctly point out that ventilation and airflow needs to be examined carefully at every school. Unfortunately, there are resource limitations such that it may not be doable to change any of that in the short term. It's unclear what the status of the most schools are in Ontario in terms of their ventilation. There's a lot of specific measurements that need to be taken in a hospital or in a school to determine the airflow and the capacity to clear out virus or to clear out the air. But certainly all of that should be reviewed very closely. Ventilation is important because the more stagnant the air is, the less air exchanges, the more likely the virus can stick around in the room. Even though the virus is not primarily transmitted via the airborne route, it's still an important aspect. So certainly schools, especially older ones, should be examining their air exchanges and ventilation as they open up.
Another aspect I know of concern is just all the time that kids spend outside the classroom. We're talking recess, washroom breaks, lunch hour. What would be, from your perspective, in terms of, again, prevention and control, what would be your guidance on those levels?
Yeah, those are going to be big challenges for schools depending on the age of the students, but the same principles that we apply in public spaces or in hospitals are the same principles you'd want to apply in the schools in these outdoor settings. Although transmission is less likely to occur outdoors, you still want to be sure that students are keeping their distance, that they're washing their hands before they're eating lunch, or before they're eating a snack, or before they're coming in contact with one another. So those are the same principles that we want to employ in the public spaces we want to employ in school. And the best way to do that is to educate students as soon as possible about how to do that properly.
And what do you say to parents in terms of balancing the need to support their kids going back to school with the need to maintain the health and safety of their family?
It's a big challenge. Every student and every family is going to have to make their own decision about what they think is safest for them. Everyone has a different sense of risk and what they think is acceptable. And then on the other side, how they value the education of the in-person education that their students are going to be getting. So there's no right answer to this question. And I think parents could be reassured by what their school is doing in their area to make sure that their kids are safe. So in order to get that decision, or to make that decision, I think parents need to get educated about their specific school. What is going on in their school? What are the safety measures being put in place? And that'll help make their decision for them.
And another tough decision in terms of assessing risk and safety is grandparents. I mean, there's a lot of grandparents that help out with dropping kids off at school, picking them up after school, even with after school care. So what's the implication for them in terms of continuing to help their families and the integrity of their bubbles? Because, their kids now are being exposed to a lot of other people throughout the day.
Yeah, the grandparents is an important issue. It's very hard to manage that risk because there's when you think about the bubble and the proposal of what a bubble is supposed to mean, having a contained number of people who are exposed to one another, that automatically changes or breaks whenever your child is sent to school, because now everyone in their classroom is considered part of their bubble, and then by definition, the extension goes on and on and on. So when parents are thinking about whether to involve the child's grandparents in immediate care after school or around the time of school, they need to think about what their childcare needs are and think carefully about whether there is that grandparent is at high risk of acquiring COVID. So if possible, and I know this isn't easy, it would be good to try to minimize that exposure, given that that bubble is opening. But of course, that won't be possible for most people, in which case what parents can try to do is lower risk by keeping distance as much as possible, by washing hands, by being very careful to watch for symptoms, by minimizing the amount of contact time as well. So it's not an easy question for most families because they do rely on the grandparents for care. And I think as the first few weeks start to develop and when the schools reopen up in September, I think parents will start to have a sense of what they can do practically to protect themselves and their loved ones.
What about reporting? Like, what if worst case scenario happens and we get, say, outbreaks, which can vary in number? I mean, an outbreak actually could consist of one positive case, but what should be the protocol in terms of school reporting if cases do begin to emerge?
The schools, there was actually a document that was released yesterday by the province. Ontario Health released a document describing what schools should be doing to manage outbreaks. So what you find in there is that if there's an outbreak in a school or in a classroom, which is defined on the classroom level, or should I say an exposure has occurred, defined as even having one student having had COVID, those cases are of course reported to public health. Public health works with the school to determine who was exposed to that student, and then people are notified about what the exposure was. As an example, they provide in the document, if one individual in a classroom is confirmed to have COVID, all the other students in that classroom are considered exposed, and all will be quarantined for 14 days, even if those individuals don't show any signs of symptoms. And of course, the person who was confirmed to have COVID will also be staying at home for 14 days. So in that document, there's all sorts of recommendations and details explaining the relationship between the schools and public health units across Ontario.
I'm curious, Dr. Vaisman, what happens to the teacher and any other staff that have been in contact, say, with that one child in that one classroom?
Yeah, the people who made in contact with that student in that classroom, they will all be considered exposed, and in which case those people will have to be quarantined for 14 days. So a teacher, a fellow student, teacher's aide, anyone who was in that classroom with them, according to the definitions they're using. Of course, this may change based on specific public health investigations that occur, but that is the general principle that will be guiding them. I think they're taking a very conservative approach based on feedback they've received, and also based on the anxieties and the concerns correctly by parents about the safety of their children. This may end up leading to a significant number of people being quarantined, but in cases where you want to contain the spread, people will go above and beyond of what's necessary to try to reduce that spread. And I think that's the safest thing and the right thing to do in these cases.
Okay, so a few non-back to school questions, and then we'll move into our audience questions on Slido. The issue of airborne transmission of the virus, it continues to be debated in the medical science world. And I'm hoping you can maybe help clarify the recent sort of debate that's been going back and forth. My understanding of airborne is those are droplets that are lighter than the ones that fall to the ground within 2 meters. And what I'm reading is the debate is over whether these lighter ones remain suspended in the air for extended periods and therefore can transmit the virus, or should be considered to be transmitted, potentially to transmit the virus. Can you help clarify what's going on here?
Sure. So this term that we use, airborne, there's a colloquial definition, which I think most people understand to mean that it's transmitted through air. And then there's the definition that we use in healthcare settings, which refers to a distinction between droplet and airborne transmission. Droplet transmission refers to somebody sneezing or coughing and large droplets being generated and being carried approximately 6 feet away from the individual and infecting anyone in that radius. Whereas airborne refers to the generation of very, very small droplets that are suspended in air that can carry the infection potentially many meters away and potentially many other rooms in the same space. So I think that's where the misunderstanding is among the public and among some other people about what we mean by airborne. When it comes to COVID, it's important to recognize that likely the predominant way of transmission is through droplet. This is the way that we've been using this, thinking this is how we've been protecting healthcare workers and patients in hospital settings.
Droplet meaning the heavier droplets that fall to the ground because they're heavy enough to fall within 2 meters.
That's right. So let me give you an example. If a patient has COVID in a waiting room, for example, if the patient, that person isn't likely to infect an entire waiting room, whereas if that patient had measles, which is transmitted through airborne, that is much more likely to occur, in which case we do contact tracing for everyone in that room. Whereas with COVID, we would do a more limited approach, a more limited exposure follow-up. So in discussions about COVID, it's also important to recognize that although we say droplet is a predominant form of transmission, it's not the only form, and likely it's on a spectrum whereby there are likely small airborne particles that are created when somebody coughs or sneezes, but that's not the predominant way that it is transmitted. In healthcare, that has an important distinction in terms of using what we call N95 respirators and placing patients in special rooms. But in the public, the most important distinction there is that, when you're sitting in the subway, for example, and you're several meters away from someone, if they're not wearing a mask, or even if you're not wearing a mask, the likelihood of transmission is low as the distance increases several meters away. So that's the important thing to think about. It's not actually in the air. It's likely suspended for a short time and dropped. We discussed earlier about ventilation. Of course, ventilation affects that as well. In poorly ventilated areas, it's more likely to stick around in the air. Again, not because this is on a continuum. It's not a dichotomy.
Can I ask, what's your sense of why this debate continues? Because it's been going on now for what, seven months?
Yeah, I think it's because everyone is very concerned about the safety of patients and healthcare workers. Everyone wants to do right by them. And so we want to be sure that we're doing this correctly. So it's always important to raise the question of how this virus is transmitted. And also, because this is the number one research topic in the world right now, you will hear many case reports and many investigations into this very topic. So there's lots and lots of people around the world looking at this very topic, and it's sometimes hard to put it all together. And that leads to potentially conflicting data or to data that's not consistent with what we previously knew. And then hence, every time something like that shows up, we always revisit the topic. And so it's a good thing. In fact, it's good. It's always good to have good scientific discussion about what the right thing to do is, because we always want to do what's best for our healthcare workers and our patients. So it's good that we are having these discussions.
Fair enough. A lot of buzz this week surrounding news out of Hong Kong, where it's been confirmed a 33-year-old man was infected with the virus for a second time, 4 months apart. So help us put this in perspective, because we're talking about the first confirmed case of a repeat infection out of 24 million cases worldwide. So why the big buzz about this?
Yeah, it's having had the first potential or now confirmed reinfection, it changes our approach potentially to how we test patients and how we isolate them in hospital settings. It's not that we were surprised that people could be reinfected. We know that people with seasonal coronaviruses can be reinfected by the virus. What it does tell us now is that this is not only a potential, but it certainly does occur. And so going forward, whenever we see a patient come back with symptoms who've had the virus before, we need to consider this as a possibility that the patient is in fact reinfected with the virus. Some implications include having to retest people frequently or having to retest people periodically in the future, and also having to re-isolate them in hospital if they have symptoms consistent with COVID again. So this is also important potentially for vaccine development. We don't know how this affects vaccine development yet. The suspicion from most experts in the field would say that this doesn't yet tell us that vaccination is going to be ineffective. Again, we don't know that yet. We don't know until we try and see what happens with vaccination. It may mean that there is going to be a seasonality to the COVID, perhaps, or maybe not a seasonality, but a periodic waves, because people can be infected and then reinfected again, and then a whole population can go through the whole experience again. So there's many, many implications for this. One thing that we've discussed previously about is herd immunity. If you can get reinfected by a virus, then herd immunity is less of an effective tool to control the spread.
Not that it was much of a useful tool in the first place.
Right. There's always that silver lining that when there's a large number of cases, at least it confers some protection. But now that's less. Not to say that it's not a factor, because one interesting implication of reinfection, it could be that the second time you have it, you have a far less worse disease, and maybe you're not transmissible as you were the first time. But it's less of an important tool than it was before. It's not completely gone, but it's not as hopeful as it was before.
All right. The daily case count across Canada continues to skew upwards, and my understanding also in terms of the profile, it continues to skew younger in terms of the new cases. And within that group is emerging a new cohort that I read about in a poll by Angus Reid called cynical spreaders. And what I found interesting is that this identified 1 in 5 Canadians in this group as cynical spreaders. These are people who have, quote, expanded their social circles, don't physically distance, and are ambivalent towards hand washing and mask wearing. What would you say to these cynical spreaders?
I think most Canadians, if you look at another optimistic way to look at that number, is that 4 out of 5 people are not cynical spreaders.
All right.
8% is a good thing. But we have to encourage those individuals to remember how bad it was. It's easy to forget sometimes when you're out of a crisis how bad the crisis was. And it's also even harder to convince people when Canada's crisis wasn't the worst one in the world. There were many other examples in the world where people were in far worse situations. So people might take it for granted. And that's part of the problem with prevention in general, is that when you do prevention well, nobody knows that anything's been done at all. So these individuals are getting complacent as a result. I think it's important to recognize that this is not going away anytime soon, that we are just as much at risk of another wave of COVID as we ever were. This messaging needs to go directly to those individuals. I'm not sure what the most effective way is. That's the million-dollar question that also applies to every other public health measure that we want to introduce. But that absolutely needs to be messaged consistently to those individuals specifically.
Absolutely. All right, let's get to our audience questions on Slido. We're going to throw those up there momentarily and let you weigh in, Dr. Vaisman. Well, for some reason, they've been minimized. Let's see if I can get it back. I can. Look, here we go. First question. Once our grandchildren go back to school daycare, should we no longer be part of their bubble and go back to physical distancing from them? So again, the grandparent question.
Yeah, that's a very tough one. I think every family is going to have to make that decision for themselves and look at how the health status of the grandparents as well. Some people rely heavily on a grandparent to provide care for their grandchildren, so there isn't much option for them. And in that case, what you can do is just try to reduce risk by being very vigilant. But there's other people who do have the luxury of having other people provide care for their grandchildren, and where they can have the grandparents excluded, in which case, that's advisable if possible. They should recognize that once a child goes to daycare, they're now part of the grand bubble, that they're exposed to a lot of other individuals. And so it's certainly possible to acquire the virus now. One approach for families is to take a tentative approach in the beginning, have the grandchildren involved with the grandparents and see what happens, see if cases begin to rise, and then change their plans accordingly. Going back to reintroducing grandparents to grandkids would have to come somewhere down the line when we know that cases are falling significantly. But again, there's no easy answer to that question.
It's going to require a lot of vigilance on the part of parents daily, really, to be monitoring how this whole return to school protocol works. Mm-hmm. Next question. I'm a teacher, and I want to know if I should be worried about touching papers my students have handled, and also if I should be changing out of my clothes before I enter my home after work.
So the bottom line with what we call fomites, which are these objects where the virus can be transmitted through, is that you can't pick up the virus unless that virus goes into your mucous membranes, your eyes, nose, or mouth. So if you're touching papers, and papers are a very unlikely source of the infection to begin with, or clothes for that matter, your way to protect yourself is to just wash your hands frequently, and especially wash your hands after you've touched your clothes or those papers which you're concerned about. The second thing you could do is just minimize touching your face in general. So, the virus isn't going to jump off the paper onto your face. The way it'll get there is by you touching the paper, then touching your face. So we all, myself included, have to do a better job of just not touching our faces at all, or minimize it to the point where we're only doing it after we've washed our hands. So those are the two things you could do to prevent any transmission. Again, the overall risk of transmission from a piece of paper is low to begin with.
What about clothing?
Yeah, similarly, the transmission from a piece of clothing is low, and you can mitigate that risk by washing their clothes at the end of the day, not wearing them around the house, and then again, washing your hands before you're touching your face, for example, when you're eating.
All right, next question. Can you please provide information about the antibody test for COVID? Example, how does one go about getting a test for COVID antibodies? If a person had COVID in February, would they still have antibodies now? So that's kind of a two-parter. If you want to tackle the actual antibody test first.
Yeah, we don't have a readily accessible antibody test available in the acute care sites quite yet. In America, just yesterday, the FDA approved a rapid antibody test to be done like as a home kit. So we'll see what that shows. We'll see how effective that is and how it works in the public when they use it. But in Canada, what we have access to is foreign tests. You can order them online, I suppose, and have them shipped to you. But they're not really ready for prime time or approved yet in Canada at this moment. As for the duration of antibodies, that's a question that's still up, that's still unclear, is how long will these antibodies last and in which individuals. So there may be a difference in the individual's ability to have lasting antibodies. For example, in elderly individuals, we know from other diseases, they have a shorter period where they will have the neutralizing antibodies in their blood compared to a younger person who might have it for much longer. So that answer about whether you're last from February, that depends on who you are, and we don't quite know the answer yet.
Right. You hinted at this earlier. How close are we to having a widely available, inexpensive saliva test for COVID-19 available here in Ontario? And in your opinion, how could that change strategies for opening schools, workplaces, etc., more safely moving forward? So again, a two-part question, Dr. Vaisman.
Yeah, I'm not sure exactly how close we are. We know that there's lots of stuff out there being done, and in Canada, this could be even weeks or months away from being available in Canada. It's been studied pretty well now in other countries, so it could be approved by the federal authorities fairly soon and could be ready in the next few weeks or months. And how does it affect the pandemic? The most important way it affects the pandemic is being able to recognize and diagnose patients faster. So if you can do a saliva test, if you can go to a clinic, pick up a specimen container, provide the saliva, get the answer back within a day, that's a lot easier than having to stand in the line for an assessment center, for example, and getting a full assessment. Of course, people who are ill will still require an assessment, but if you're only mildly symptomatic, or say you're an exposure from a person who had the disease, now we can more rapidly, if we have the saliva test, more rapidly identify you. Why that's important is that the more people we identify, the more people we can isolate, and the fewer exposures we're going to have after exposure to the initial case. So
exactly. Yeah.
That's an important piece.
All right. Next question. Would a portable air purifier be effective in a classroom or portable that has no HVAC system?
Yeah, it's a tricky question to answer, because when you introduce any kind of air purifier, or for example, a HEPA filter into a room, what happens is that the air in that room is now, they're potentially introducing turbulent flows. So virus that potentially is in the room that's sitting on surfaces might be lifted off the surface if there's turbulent airflow in that room. So you might actually be increasing the risk of transmission. It's not likely a high risk depending on the setting, such as a open large room versus a tiny poorly ventilated room. But it's not clear that necessarily introducing an air purifier is the best option. In some healthcare settings, we do it when we're doing a very risky procedure that generates a lot of aerosols, but those don't occur in the public. So it's not generally necessary to introduce portable air purifiers in those settings. There may be some specific examples, like a very poorly ventilated small room where it may be helpful, and the benefit may outweigh the risk there.
Right, right. All right, next question. There are reports that many patients who have been classified as recovered from COVID are in fact experiencing long-term negative effects for months after they first contracted the virus. What have doctors learned about this subject in the last few months?
Yes, there are many potential manifestations of people who have had COVID and are recovering from it. Similar to some other viruses, we've seen also that people may have chronic fatigue related to having COVID, perhaps muscle issues. We know also an important side effect is having cardiac or heart issues after having had COVID. We've seen many examples of that, and also this has been well reported now. So the muscles of the heart can be affected in the long term after having COVID. This doesn't affect most people, but there is a substantial number of people who have had these side effects. Now that we're 9 months, approximately 8-9 months out from the beginning, now we're going to know better about what the prevalence of this disease is and whether it gets better or not. It's possible that people have chronic symptoms and then those will go away, or it's possible that these chronic symptoms will persist. And only time will tell in the next few months what the case might be for those individuals.
Next question for you. Should one of our children test positive, does that mean the entire household goes into quarantine? And if so, how can we make it safe for the rest of the family?
Yeah. So if you look at the public health in Toronto, for example, or other public health unit, their recommendations, if you're an individual living with somebody with COVID, you're considered to have been exposed and you yourself should be quarantined. Ideally, people should be quarantined separately, but in the case of a household where they've all had the same exposure, then practically speaking, it's likely most of them, or they will actually just quarantine together in the same home. So in those cases, we know that approximately 15 to 20% of household members will acquire COVID if one individual has COVID, which may seem high, but again, going back to our airborne versus droplet discussion, it's actually low compared to airborne transmitted diseases. So there isn't, when you're living with an individual with COVID, you can do your best to try to reduce the likelihood of transmission. For example, trying to segregate them from the rest of the house, not sharing food, not sharing utensils, washing hands, not sharing a washroom. But that's not going to be practical for everyone, especially if the child is very young, or if there's an elderly person in the house who needs care and you can't separate from them. So it's not always going to be practical, but it's the things that we've been talking about the last few months that you could try to do to reduce transmission.
Right. From Angela, thank you for taking my question. I'm wondering if mask wearing and social distancing in schools is enough for students and staff to remain safe, or does the quality, let me just read that again. I'm wondering if mask wearing and social distancing in schools is enough for students and staff to remain safe, or does the quality of ventilation in the school pose a greater concern?
Yeah, it's a great question. Is what the status of the ventilation is in your local school. Um, Again, it's hard to know because there's so many schools and the ages of the schools are various. Likely that the newer the school is, more likely the ventilation is better. Certainly, mask wearing and social distancing will always help. I think it'll have to be a more extreme example of very poor ventilation for those things not to work, for you to have a situation where potentially several people with COVID are in a tight room with that's poorly ventilated, for those people to still be affected by COVID. But I would say that people should just try to do their best to get information about their local school, about what the situation is. That may not be readily available, but if it helps them to understand and to make a decision about returning to school, then they can inquire with their school to figure out what the status is.
Right. Next question. Our children will be attending school in the fall. Anytime they have a sniffle or sore throat, should we go for a COVID test?
Yeah, that's going to be a big challenge because the capacity in Ontario right now to do COVID testing in such a broad scope is probably not quite there yet in many parts of the province. Hence, going back to that saliva test would make it much, much easier to do that. It's going to be very challenging. And I think what's going to end up happening is that people are going to be very conservative and want to test as many people as possible. And that's certainly the right thing to do when we're talking about a pandemic. So even mild symptoms that we wouldn't have thought twice about before are likely now going to require you, or likely going to prompt testing. If this is readily available in the school, it may not be a big hassle to do that. If it's not available in the school, then it's going to require easy access to care from somewhere like an assessment center or a walk-in clinic, for example. But I would imagine that given all the concerns and anxieties around schools opening, that many people are going to take the approach to have a low threshold to testing, which I think is the right thing to do.
Mm-hmm. Next question for you. I read that autopsies on people who passed away from COVID revealed blood clots in multiple areas in their bodies and not just in the lungs. Does that mean that individuals who carry genetic mutations that predispose them to blood clotting are in a greater risk for dying from COVID-19?
I don't specifically know of any studies that examine the question about those with clots having a higher risk of dying. Indirectly, we do know that people with multiple comorbidities, which would include any kind of what we call a prothrombotic disorder, have a higher risk of complications related to COVID. So it's not, it's reasonable to believe that if you have a genetic predisposition, you may be at more risk of having complications from COVID, including higher mortality. But I just don't know whether there's a specific study that actually has confirmed that link between the two. So it's potentially there, but yeah, that's pretty much it.
This is a great question from Beth. My grade 12 daughter will be going to school alternate days. Is one mask sufficient per day? Should it be washed daily? Which I would presuppose that means it's a cloth or a cotton homemade mask.
Yes, so that's, yeah, certainly if you're using a cloth mask, it should be washed daily. If you're using a surgical or procedure mask, you should throw it out at the end of the day and use a new one the next day. Is one going to be sufficient? So the reasons why you would switch out your mask, for example, a procedure or surgical mask, would be if it's gotten very moist, if it's damaged anyway, if it doesn't fit tightly on the face anymore, or it's been contaminated due to somebody sneezing or coughing on you. If any of those conditions are met, you should throw out that mask if it's a disposable, or throw in the laundry if it's not a disposable, like a reusable mask. So is one sufficient for the day? Likely it will be, but I think students just have to be aware of those indications and change them accordingly.
Mm-hmm. And it probably doesn't hurt to have an extra one in your backpack
Yes.
or whatever.
Yes, exactly. Great idea.
All right. Phyllis Burke wants to put you on the spot here, Dr. Vaisman. Would you send your kid to school if you had any? Now, I know you have a young child who is preschool,
Yes.
but give it a shot. What would you do?
I think it's reasonable to send, if I had a child, I personally would send my child to school with the current plan in place. That's not to say that things might not change and it may not be the best idea down the road if, say, the volume of cases goes up or if the procedures are in place seem to be inadequate. But personally, I think I would. I just want to also tell the audience that, again, everyone has their own opinions and their own risk threshold. They may not be the same. You may have a mom or dad who's immunocompromised and you don't want to take any chances with your kid. That's perfectly reasonable. You may not believe that the science going into reinstituting kids in schools is good enough and that it's safe enough. And again, everyone has their own decision to make regarding that. And as you said, 40% of families in Canada would decide not to, but that also means 60% of people have made the decision that it's sufficiently important for them. They've weighed the risks and benefits, and they believe that it's more beneficial to send the kid than not to.
Yeah.
But that's going to be up to every individual.
Exactly. From Gwen, what is your best guesstimate for a date for a successful vaccine treatment for Canadians?
It looks like so if you look at America, partly due to the involvement of politics, they've been speeding up the vaccination phases. The Moderna vaccine that we've been hearing about from a company in Massachusetts, they have received approval to do a phase 3 trial, which should start in September. So if that's successful, then we could potentially see a vaccine by the end of 2020. I think the most reasonable estimate would be the beginning of 2021. But who knows? Who knows how that phase 3 trial is going to go? They've already enrolled 13,000 people. They're looking for a total of 30,000, which they probably will get. It won't be very, very hard to enroll people in the trial in America. So we'll see what the results of that is. Some time does need to elapse in order to see whether the antibody response is consistent, if it's lasting. Mm-hmm. So there is some built-in time into the structure of the study to begin with. So you can't just, no matter how many approvals you get from the government, you still can't speed it up to immediate, right? Unless you just take a big chance with it. So reasonably thinking, I think the early 2021 would be the most reasonable early time what we can expect it.
Alan McEwen has a question that reminds me of some of our first live streams back when the virus was just ramping up. Do you feel it's necessary to wear a mask when walking on the street?
So I personally don't think it's necessary when walking in open spaces where there aren't a lot of people around you, because it's unlikely to be able to transmit the virus in these areas. If there is any kind of crowding, if you don't believe that you can keep a sufficient distance, approximately 6 feet from other people, then yes, you should wear a mask in those settings. But there's lots of situations where you're walking down a residential street, there's nobody around you, there's no point. Or let's say there's somebody coming down the sidewalk, you can move out of the way. But if it's a busy city street, that's a different scenario. It makes sense to wear a mask. So I think you have to evaluate each situation and then make a decision for yourself.
Right. All right, next question. Do we have information or more information on how long this virus lasts on different surfaces? And if, for example, when one orders food from restaurants, would heating the food before eating it kill the virus if it's in the food?
So we don't have a lot of information of how long it lasts. We do have a range of somewhere between hours and maybe up to 3 days at most. but that may not mean that the virus is readily transmissible at that length. Initially, we thought fomites are a big concern in terms of transmission, but that has been less emphasized recently. By fomites, I mean these other inanimate objects that potentially transmit the virus. As for food specifically, it hasn't been so far identified as a source of outbreak, despite there being numerous restaurants open across the world, especially in places that have had the virus and had waves. That hasn't been identified as a source of outbreak. People have more likely acquired COVID in restaurants from close contact with other individuals, but not from the food itself, as far as we know. So I wouldn't be too concerned about eating the food. More important aspect when you're eating is to wash your hands. That is by far a more important reason or way that you'd get infected, is that if you're eating with your hands and you're not washing them, you've touched all sorts of surfaces when you've entered that restaurant. You've touched even before you've entered the restaurant, you've touched all sorts of surfaces. So you can prevent a lot of that by washing your hands.
All right, next question. I work at a library. We'll go back to work next week. Will homemade cloth face masks be good enough to protect me, or any washable face masks, are they good enough?
Yeah, the types of masks that you can buy from stores, the reusable face masks are generally pretty good. When we talk about bacterial filtration efficiency or particle filtration efficiency for surgical masks, it's somewhere between 90 and 98%. As for these masks, it could vary in a very long, wide range from 20% all the way to 90%. The way you can improve it is by making sure the material is good and thick, and also inserting a filter, which some people have done, which is also raises the filtration efficiency of the mask. So I think for most people, for most kinds of the work that they do, a homemade cloth mask is sufficient. The exceptions would be healthcare and any kind of place where you're likely to see health patients with COVID. Then we wouldn't use a cloth mask, but in generally speaking, in public spaces, then cloth masks are sufficient.
All right. This looks like a two-parter, Dr. Vaisman. How can as a parent make sure kids in junior kindergarten and senior kindergarten follow social distancing, wear masks, etc.? And what is the chance of age groups from 5 to 18 years contract COVID-19? Can they become carriers?
So how do you make sure that kids follow social distancing? I can't really answer that. I'm not an expert in pediatrics or in childhood education, so I don't know what the best methods are in encouraging children to do that. All I could say is anecdotally, there's going to be a variety of children in terms of response to doing this. Some kids are going to be very good at it. Some kids are not.
Mm-hmm.
Again, anecdotally, I could say is that I was personally surprised to see how many kids are good at it in public spaces, seeing them wear masks. I would have thought initially that it would be just very unlikely for them to tolerate, but I'm surprised to see that they are. So I'm not able to answer that question in any more detail, unfortunately. As for the second question about the transmissibility of the virus, there is data from Korea showing that people age 10 and older are likely as transmissible or have the ability to transmit the virus as adults. So we should think of those individuals as potentially having the same capacity of transmitting, whereas children under that age have likely, although again, hard to tell, likely a less ability to transmit the virus to other people. As for the term carrier, we don't really, when we think of carrier, it's not really the correct term to think about with viral respiratory infections, because it's an infection that you get and then you clear it. Carrier can sometimes refer to that, but more commonly in medicine, carrier of an infection refers to somebody who has perhaps a latent infection that they have for long periods of time, maybe even without knowing it, and can transmit it. Whereas COVID, you have a high viral load at the very beginning, and then it starts to go down over the course of several days, up to perhaps 9-10 days, at which point you're no longer transmissible. That is likely the same pattern that children experience as well, just like adults.
We're getting near to the end of our time. I think one more question, hopefully. A couple of weeks ago, I read in the news about a study that came from Stanford University mentioning that children may spread COVID as much as adults do. What is the status of the consensus on COVID in children in the context of recent studies?
Yes, as I was referring to earlier, likely children 10 or older have the same level of transmissibility as adults, whereas children younger than that likely have less ability to transmit the virus. We also know that children are far less likely to have bad outcomes from COVID. That for sure is true, that the older you are, the more likely you have complications and die as a result of the virus. So that piece of information, which was established in China back in January, that piece hasn't changed since then. We do know that there's other complications that's new. So, for example, the Kawasaki's, which is a viral complication with other viruses as well, that's a complication of COVID. But as for mortality, we know that it's not nearly as high in children as it is in adults.
Okay, we've very quickly again come to the end of our time today. To all of you out there, thank you for joining us. And to Dr. Alon Vaisman, UHN infection control physician, thank you once again for sharing your expertise and joining us. Really appreciate it.
Thank you.
This live stream will be available on the Foundation YouTube page shortly. And for anyone interested in donating supplies or support items for our frontline workers, you can email COVID support, that's all one word, COVID support @uhn.ca, and someone at the Foundation will be glad to help you out. And as always, we ask at the end if, in terms of donor support, it's critical for us in terms of research, for people on the front lines in terms of protection. If you are able to give, we ask you to consider making a donation. Visit www.tgwhf.ca/help now. Thanks for tuning in. Keep practicing physical distancing. Wash your hands often, mask up, and stay safe, everyone.